Good morning, everyone. Welcome to our final session 8 of our California Bridge Bootcamp for Champions series. Oh my gosh, I can't believe we did 8 of these and survived most of a pandemic. You know, it's still going on out there, so I hope everyone is staying safe. Hi, Melissa. Nice to see you. It's always good to have you here. Oh my goodness. Oh, hi, Rebecca. Rebecca is a new pediatric psychiatrist champion at the Children's Hospital of Orange County. I'm so excited to have you here. She's going to be working with us on our youth grant. Hi, everyone. If you want to go ahead and use the chat to tell us where you're joining us from and anything else you want to share. Hope everyone's having a good summer so far. Oh, lots of names here that I don't know, which is really exciting. So excited. I know that this topic has been very sought, so hoping that it drew some folks who might be new to California Bridge. Oh, yours are my favorite webinars to attend. I will Venmo you $20 for putting that in the chat after this is over. Hi, Melanie. Nice to have you. Welcome. Excellent. Sabrina from Oakland, right down the street from my house. Love it. Hi, everyone. Great. Oh, yay. Susan at Sutter, downtown Sac. Cannot have enough substance use navigators in Sac. You are part of a good group of people doing that work in downtown Sac. Excellent. Psychiatrist in the Inland Empire. Wow, that's a hard job. Thank you for the work that you do. Yeah, nice to have you. Awesome. Hello, welcome Scott from Humboldt. Oh, excellent. Nadine supporting race, one of our favorites here at California Bridge. So we'll get started in just about a minute here. Excellent. Welcome from North Carolina. I love it. Programmatic staff member. Always feel free to reach out to us. Keep in mind, we are available to talk to you about implementation as well as these medical topics. So anything you ever want to brainstorm about in terms of how we've built our program out here in California, you can reach out to us from any state. We love talking about what we've learned in building the scale that we've built in California and how it can apply to other places. So we are reaching a critical mass here, and I know that folks will be joining throughout the hours. So I'm going to kick us off here. I'd like to introduce Dr. Hannah Schneider and Rebecca Trotsky-Sir, two of our founding clinical champions for the California Bridge model. They are going to start by telling you just a little bit about what we're doing over here at California Bridge, and then dive into this topic that we just cannot seem to field enough questions about, which is what we know about stimulant use disorder treatment. So take it away. And a reminder that if you do have questions, just to please send them to all panelists and attendees so that folks can see the dialogue that's going on.
Hi, everyone. I'm Hannah Snyder. I'm one of the directors of California Bridge. Thank you all for being here today. Rebecca and I are going to talk to you so far about this talk we've entitled Meth and Cocaine, What We Know So Far. And the reason we entitled it that is because this is a rapidly changing field, and we are all kind of collectively crowdsourcing ideas for how to manage stimulant use disorder in the acute care setting. So we're going to be really, really excited to see what you guys put into chat today. If you have something that is really working for you in your community, put it in. If you've tried something and it's not working for you in your own community, please put that in as well. So we are always required to share with you that California Bridge is a program of the Public Health Institute, and we are significantly funded by DHCS. But what we're going to share with you today is really Rebecca and my opinions, and not those of the state of California. We don't have any financial relationships to disclose, but we do want to flag for you that many of the medications that we're discussing today are going to be off-label for their treatment for stimulant use disorder. I'll briefly talk about the California Bridge model. I think most of you know this well because you're here with us today, so welcome. Our goal is really to have 24/7 access to high quality care for substance use disorder in every California hospital, and you can see from the number of folks on the call today that we are well on our way to that goal. Each of our hospitals is working on these three main pillars of treatment. We really started our treatment with opioid use disorder, but as you can see, are now expanding to all substance use disorders and really any care for people who use drugs and alcohol. So the 3 pillars of our treatment are always going to be rapid access to evidence-based treatment where we have it available, connection by our substance use navigators to longitudinal care and community, and then this culture shift, this culture of harm reduction and decrease in stigma. And that is, I think, one of the most important things that we're going to be talking about for you here today. We want to kind of note that we spend a lot of time talking about opioid use disorder in California Bridge. This is the work that we were originally funded to do. We know there has been a surge in overdose deaths from opioids, but really, particularly in California, we are seeing a large increase in our deaths from stimulant overdose. And I think it's really important that we stop and pause and focus for a minute on our stimulant use disorder patients, both those who also use opioids and those who use stimulants alone. So I wanted to kind of throw up this rather sobering graph showing this increase in overdoses from psychostimulants that I think we need to really take note of and use this to kind of drive us to more mindfully treat people with stimulant use disorder. I would be remiss if I didn't speak briefly to the fact that in stimulant use disorder in particular, there's been a huge amount of racial disparities. We really see this play out, particularly in cocaine. So today we're mostly going to talk about methamphetamine because we do have such high rates in California. But we should point out that the burden of incarceration due to stimulant use disorder has definitely disproportionately fallen on BIPOC populations. And you can see this with the truly horrifying discrepancies in sentencing guidelines between crack cocaine and powder cocaine. And we just kind of want to note this to say that whenever one of our patients, particularly one of our BIPOC patients who uses stimulants, is approaching the healthcare system, this can be really triggering because of experiences that folks might have had with the criminal justice system, with policing in the past. And so just really trying to be mindful and compassionate and decreasing the stigma and being mindful of the racism that our patients have faced along the way. And this is just one more sort of sobering statistic to put out there, just showing the complete disparities in the rates of incarceration, particularly for stimulant use disorders among different racial and ethnic groups. That is a conversation of its own and a talk in and of itself. And we've actually had a couple talks on that in partnership with the National Harm Reduction Coalition. So I do really encourage you all to look back at those talks that we've given in the past and continue to have that conversation with us. But for right now, Dr. Trotsky-Skura is going to kind of dive in a little bit to some of the more practicalities of treating stimulant use disorder in the acute care setting.
Thank you, Hannah. So one of the miracles that we have uncovered with California Bridge is the fluidness of context-based and setting-based diagnosis and jumping to treatment without kind of a lot of hurdles between seeing a patient and then providing them with multiple solutions and menus of options to promote care. So our next set of slides is talking about how we come to diagnose methamphetamine and stimulant use disorder. So depending on where you're sitting, and I have the wonderful opportunity to flex across an urgent care setting, an ER setting, a hospital setting, and primary care setting, our patients will come to us with many different complaints, and kind of having that filter in our brain to be like, could this be related to substance use disorders? How is it related? And what they're presenting to me, mindful of the fact that there's this whole decades of legacy of their engagement with formal systems of care, whether that's school, whether that's the healthcare system. Like it is super important to allow patients to tell us their stories, and then also filter in, like, could this be related to methamphetamine use, stimulant use, and try to take as many conditions that are bothersome complaints to our patients and put them in the appropriate diagnosis and treatment bucket so that we can help them move forward with healthy lives. So one of the challenges that we have, or opportunities we have, is thinking as we reflect as providers, how our patients share their lives with us often can trigger a lot of emotions with us. And I've heard this recently over the past maybe year or two, really paying attention to it. When our patients tell us that they're using methamphetamines, there's different ways that practitioners can respond. So I just want to kind of read through some of the things that people have told me in the past year or two, and then just sit with your, what's your gut check on that? And then recognize that your gut check is super valid, and it helps us make sure that we're providing as unbiased care as possible. So if your patient tells you something like, hey, I use methamphetamines because I had ADHD as a kid, but I was never really formally diagnosed, like, does that shift how you feel about that situation? What about if they give you a story of, I'm using methamphetamines because I need to stay on guard overnight because I'm unsheltered and I'm living in the park and I really need to attend to all my things and be on guard? Or what about, somebody who's, a very hard worker who's really using methamphetamines kind of as an adaptive strategy for the side effects of end-stage capitalism, which is, I'm working a crappy job that doesn't give me enough money to make ends meet for my family. So I'm working nights in the warehouse and I go to a dishwasher job and then I have to take care of 3 kids. Like, that's why I'm using meth. Does that change how we care for that patient? And then, patients often tell me something like, I'm rounding out that low of my heroin use or my alcohol with methamphetamine use. And sometimes patients are telling me things like, I use methamphetamines because it makes the other drugs last longer. I'm saving money. Or, they're chasing other kinds of euphoria experiences, like it's improving my sexual experiences. And sometimes patients are telling us, I use it, but I don't kind of want to be, but after a couple of days, I just need it. I'm feeling so down if I'm not using it. And that's kind of a withdrawal experience. We'll go to our next slide.
Yeah, and I'll just kind of like chime in that I used to have really disparate emotional responses to each of these. And I think what Rebecca and I are both working on kind of coming to accept is that all of these are really valid reasons to use substances. People have really valid reasons to use substances, and that providers can have really strong emotional responses to the reasons that patients might give. But what we're encouraging and moving towards is this just like universal acceptance and compassion for folks, sort of regardless of the reason that they use substances. And then thinking through for each of these reasons, okay, what can I do to help this person if they do want to cut back or quit, cope with these reasons in other ways?
Once we kind of find alignment with our values and build that empathetic relationship, there are some questions that I tend to rely on to help me get to a diagnosis. And Hannah has her own language, I have my own language, and you'll develop your own language too. So the first thing is to really show up empathetically and compassionately with your patient. And the way I generally do that is normalize that patient encounter. Like, many people that I see use methamphetamines or other stimulants and feel the way you do. Like, I am here for you and I feel the way you do. And that could help me tie into their chief complaint. Like, I think I have bugs everywhere. That helps me kind of reframe and reshift that and align with what they're worried about. So I want to help you feel better. Can I ask you some questions? Wait for that yes. And then, hey, have you ever used methamphetamines? Something like that really gets me quickly into more of a, aligned diagnostic therapeutic model. Hannah, do you have any questions that you tend to go on?
I use really similar questions, but I kind of tie it back into the reasons that a patient has been presenting to me. So particularly in the same way that you've done here, if I know that a person is experiencing homelessness, I kind of try to normalize and validate and say, hey, I know it's like really hard. Some of my patients use stimulants to kind of stay awake and stay vigilant so that their stuff doesn't get stolen. Is that ever something that's happened with you? And people will kind of feel a little bit more comfortable disclosing that if they feel like you're coming from a place of understanding.
Exactly. So part of this is really understanding that we as healthcare providers, whether we are substance use navigators, nurses, or just part of the healing environment, we don't necessarily need to know all the details of somebody's life in order to help make them comfortable and a part of our community and help us make medical decisions to offer care accordingly. So I think of it as like, what's the minimal data points that I want to use in order to move forward safely and successfully? So this, once somebody's like, yeah, I use methamphetamines every once in a while, I'm kind of like, how often is this? Like 10 years ago you used once, or is this, you're using the last time was this morning, a couple hours ago, a couple days ago, a couple weeks ago? Kind of give a frame to help me understand where they're going to be at in a couple hours from now. And I'm wanting to know the frequency of their use a couple of times a day, a few times a week. I don't need precise numbers. I just want a ballpark. And then the route of use, and this helps me provide solutions for people to use drugs more safely. So I say something like, some people inject, smoke, or do other things to get their drugs in them. How do you take it? And I want to kind of elicit the multiple ways that they're probably using drugs. And then if they're using other drugs with their stimulants, to kind of take that edge off. And what we have, or in my head, I'm like, I want to boldly uncover all the other substances used in their lives. When they're using stimulants, often that becomes the biggest thing, and that's how they're identifying. But we know that a lot of times people are also using those opioids or those alcohols to take the edge off, as we've also seen in the chat. So when we have those other use patterns, we also want to offer solutions for those as well.
I think that's so important. I just want to triple underscore that, because as you're going to be hearing in this presentation, there's not a ton of evidence for most of the treatments for stimulant use disorder. But we do have life-saving medications for opioid use disorder, and we do have medications for alcohol use disorder that can make a really big difference. And so many of our patients are using sort of the stimulants to round out the opioids or vice versa. And so if we can be treating both of those use disorders at the same time, our rates of success are just going to be so much higher. So thank you for pointing that out. So that's a little bit about the kind of scenarios in which people tend to present. And you guys are putting incredible information in the chat about what you see people coming in with, how people are identifying. You'll notice that while we were kind of talking about the context, we haven't so much been talking about screening or systematic things like that. We're going to dive into this a little bit more and talk about diagnosis. So how do you actually diagnose someone as having a use disorder? Treatment, both behavioral and medication, and then living well or harm reduction. And I love this. Rebecca recently reframed for me. We've been talking a lot about harm reduction, but in the same way that we want people to be living well with any medical condition, harm reduction is really just about helping people live healthier, happier lives. Is that how you would frame it, Rebecca?
Yeah, I mean, I love the phrase harm reduction. And also I think it's a way to code to our allies that we're all on the same page. But when we're in these spaces of mixed audiences, maybe with healthcare administrators who don't really know what that means, or has some like false belief that all those weird doctors out there with the harm reduction thing. But once we start talking about like the living well and just like the normalization of care, it helps me be able to serve more of my patients with more of the things that are harm reduction. But I just reframe the language a little bit, and I feel like I'm able to pull in more of my allies institutionally.
That's great. So some of what you all put in the chat was that you're often seeing people either coming into the acute care setting intoxicated, or you're seeing people with methamphetamine withdrawal. And I actually want to take a second and talk about methamphetamine withdrawal, because I feel like we spend a lot of time talking about opioid withdrawal and alcohol withdrawal, because we know those have really obvious physical signs and symptoms. Alcohol withdrawal is potentially life-threatening. Opioid withdrawal, we're always thinking about as we're starting someone on buprenorphine. But methamphetamine withdrawal really stinks. It's a really, really uncomfortable state of being. Essentially, folks have just, when you're using methamphetamine daily, the spikes in your dopamine levels are so significant that the withdrawal of your dopamine puts you in this state of profound dysphoria, profound sleep dysregulation, significant irritability, and it's just a really uncomfortable state of being. So I feel like we talk a lot about people washing out of meth and we say, oh, they're just sleeping it off. But I think we don't also recognize the profound dysphoria that many of those patients are feeling that might lead to some of the behavioral issues that we sometimes identify. So I guess just framing this first and foremost, coming with a standpoint of compassion, both for intoxication and withdrawal, and for the symptoms that patients might be feeling at these times. I put up here a sample of what's being done actually at UC Davis Hospital. Every different hospital, every institution is going to have its own approach to this. But when people come in intoxicated from stimulants or irritable from really anything, I think the foundation of care is just compassion, being kind, giving people space, and then giving them the things that they need to control the symptoms that they're experiencing. So this is one example from UC Davis of how they kind of risk stratify the severity of methamphetamine intoxication and how they manage those symptoms. So at UC Davis, they actually use something called the Broset score, which is a score that sort of ranks people on confusion, irritability, boisterousness, verbal threatening, physical threatening, and attacking. And so based on the severity of that score, patients will be sort of stratified to different treatment levels. We're not necessarily saying that this score needs to be implemented at every hospital, but it's a way of framing kind of what we can do for folks. So if people are feeling irritable or intoxicated or maybe a little bit confused, probably the best treatment for them is actually just a quiet space. And when you think about that, if this person has come into your emergency department, chances are they're in a busy hallway, it's loud, there's alarms going off all the time. That is not a therapeutic environment, and that might be an environment that leads to escalation. So if you can put people in a quiet room, if you can give them nicotine replacement if that's indicated, if you can give them snacks, if you can give them limited vitals, kind of minimize the people bothering them overnight. And if they also have opioid use disorder, by all means treating any opioid withdrawal they might be experiencing with buprenorphine. That's kind of what we think of as the first level of wraparound services. As people become more agitated, We talk about verbal de-escalation and redirection, which we know that you all work really hard to do, but can again be difficult during a busy shift. But kind of trying first and foremost this like quiet room, dark room, calm speech to help de-escalate patients. And then if needed, these are some medications that are part of the Davis protocol, including lorazepam, diphenhydramine, and olanzapine. And then really only if somebody is acutely in a physical threatening state where there are risks to themselves or others would we consider things like restraints or IM medications. And we're putting this out here because we've known that in some facilities and in most facilities over time, sometimes we jump too quickly to these high-level de-escalation techniques. And actually what people just need is a quiet space to sort of chill out and come to a safer space of being. So it's all about this safe environment. And if we can provide that safe environment, that keeps our patients safer, but it also keeps staff safer as well. Rebecca, anything you want to add to that?
I have a busy ER, and a lot of the violence from patients that tends to land, if you think about it, on people lower on the totem pole, like our LVNs, our frontline workers, and our nurses, rather than the attendings making a lot of the like big medical decisions. So if we are talking about how to shape culture in our institutions, I really recommend making sure that we're talking to our front lines, like our security officers, our LVNs, our nurses, all those front desk people, and being like, hey, what do you know about like withdrawal and agitation? How are you experiencing it? What are you seeing? How can you let us know if you see somebody in the waiting room starting to twitch out? We can help you easily and safely treat that patient, and that's why we're here for it. So just to recognize, in the same way that like the criminal justice system disproportionately impacts like poor people of color, I think the structural violence in a hospital tends to impact our our staff workforce that tends to be like lower on the hierarchy of the hospital.
Just shout out to the chats. I'm seeing a lot of really great stuff in there. Guys, please keep an eye on it. We're not going to dive into all of them, but we'll address some of them in the Q&A section. This is really good stuff. Rebecca, I'll turn it to you for their diagnosis.
Yeah, so I think what's fascinating to me about stimulant use disorder is that withdrawal picture co-occurring with that intoxication picture. Like I think of the intoxication picture really being that aggression and like psychosis and danger to self, danger to others that's presenting in our acute care settings. And then that like sleepy kind of fatigue is a whole nother thing that's presenting like just even a few hours later, a few minutes later. And so there are structural diagnoses that we have in the DSM-5 for stimulant intoxication, stimulant withdrawal, and this is presenting you here the DSM-5 withdrawal diagnosis. I think colloquially we often say, oh, that's just a meth washout, but it is a condition that has treatment that Hannah just went over really well. So going to the next slide. This is kind of the juice that came with our opioid use disorder reframes. Is the medications for addiction treatment for opioid use disorder is so effective that technology changed lives. For stimulant use disorder, or STUD, it is really different. So for methamphetamines, we think, in my head, I'm thinking, are we treating somebody's agitation intoxication picture? Are we supporting somebody's withdrawal picture? Or are we supporting somebody's chronic care of their stimulant use disorder? And they have 3 different ways that we can provide medications and conversations to those patients. So this slide is focusing more on that kind of transition from withdrawal to a chronic care picture. So what are medications that we have in our armamentarium that's gonna help somebody with their cravings, with their long-term kind of withdrawal, like weeks out. And we have a few that they're all off-label. They're not FDA approved for this indication. Most of them are small studies showing some small effects, but they are available. And I think they're really important to offer to people and to our colleagues as resources, because it signals that we're on the side of our patients, that we're providing hope, and there is solutions for people. So while we as scientists know that these might not have the same number needed to treat as buprenorphine does for opioid withdrawal, they are effective treatments on the small scale. So the ones that we have really been turning to recently is mirtazapine, and having that quick start mirtazapine 30 or 15 milligrams, depending on what your institution likes, at night. So that's something that I just do like right away. Somebody has a stimulant use disorder, right away they're in the inpatient setting, I offer this to them, and it's not something I have to think too hard about. The other ones I'm kind of going through in my head, like, do I win? Like that's, so my go-to is Mirtaz right now. I honestly don't see this massive, like next day the patient wakes up like, woo, my life's transformed, but it is something that we have some success with, and it's shown in the evidence. Bupropion, so this is Wellbutrin, and I don't like talking in brand names, but because Bupropion is so close to buprenorphine, I will make sure to say Wellbutrin. So this is Bupropion, Wellbutrin. It also kind of works on the same pathways in the brain that get revved up with stimulants. So there's two different strategies. One is, well, mostly it's going as high as you can, as quickly as you can. So that taper for some people is, 150 day 1, 300 day 2, 450 day 3. Some people find that taper a little bit too high, and they're going on a slower taper. Hannah, what experience have you had at your institution with Wellbutrin Bupropion?
We tend to use Bupropion more in the outpatient setting. Occasionally we'll initiate it during inpatient hospitalization, but it's not something that I would routinely start in the emergency department. Unlike Mirtazapine, which seems like a little bit of a lower barrier, we know that Bupropion has some contraindications, particularly for folks with stimulant use disorder, and can have some side effects that not every patient likes. Totally dependent on the patient in front of you, if they would prefer Mirtazapine and things like a little bit of extra sleepiness to Bupropion and a little bit of extra energy, right? I like both of them. I'm seeing in the chats that there's some questions about Mirtazapine and what we're using that for, and Wellbutrin and what we're using that for. I think these are the two where I'm like, there's the most evidence, even though it's pretty slim. For Mirtazapine, I'm really thinking about in the inpatient setting or in the community setting, or as a quick start in the emergency department. So some of us are now trialing through as a QI intervention, single dose of 30 of Mirtazapine in the ED, and then discharging with a prescription for that. The thought here is really that with that sleep dysregulation that you get with early methamphetamine withdrawal and with the dysphoria that you get with methamphetamine withdrawal, that Mirtazapine can help with some of those symptoms. And so our hope is that starting this medication will continue to help patients feel a little bit better so that there's less of a risk of return to use. But as Rebecca was pointing out, really the evidence here, it clearly does make a difference, but it's a small difference with a relatively larger number needed to treat than what you would see with something like buprenorphine.
So there's a couple of things in the chat about whether there's symptomatic relief. So definitely in the acute care setting, or over the first couple of days to week, you can definitely use any of the symptomatic reliefs for methamphetamine withdrawal or intoxication type features. So like anxiolytics or sleep agents like trazodone. This slide is intending to present some options more for that transition now from those first couple of days where it's really challenging to then helping people with using less meth over time. And these are the medications that have been shown in a subset of patients to reduce cravings to use and then reduce overall use. It is again, looking at 1 in 10 patients having a significant effect rather than like 1 in 2 or 1 in 1, right? Topiramate, Hannah, I know you've been doing a little bit with topiramate in your institution. What does that look like for you?
I have mostly used topiramate in the setting of cocaine, which we'll talk about a little bit more because it has pretty good evidence for alcohol, decent evidence for cocaine, and a little bit of evidence for methamphetamine. But certainly it's an option on the table, and some patients really do like it. It has less contraindications than some of the other ones, but titrating the medication can be a little bit tricky because you need to slowly titrate over time so that you don't have that confusion that can sometimes come with topiramate.
So then there's a set of studies that are also showing that you can kind of, this is my mental model, is in the same way that methadone kind of safely replaces some of the opioids for opioid use disorder, the long-acting stimulants can be prescribed in some patients and in some settings, and it does reduce the overall use of illicit stimulants. Now, I say that full well knowing that in my particular public healthcare setting where I'm seeing a patient that I might not ever see again, it is unlikely that I'm going to be prescribing a sustained release like amphetamine salts for that patient. And there's a lot of institutional barriers for us deciding to do that. It might be a good thing for people who have like ongoing longitudinal relationships and more control over their institutional supports for that kind of medication intervention. It does have evidence, and I think it's something that some of us in the audience might be like, okay, that could work in my setting. But I suspect that many of us in these settings were like, oh man, that's never going to fly with my boss. But it's maybe something that might get to change in a few years. I'm not sure. What do you think, Hannah?
Yeah, I mean, in my practice, because I also practice in the primary care setting, it's something that we talk about stimulants for stimulant use disorder, but really primarily in the context of people who have a clear diagnosis of ADHD from the past. And it's something where you would want really a high level of monitoring. It's not something where we would recommend, as Rebecca is pointing out, any initiation from the acute care setting. It would need some pretty careful monitoring, but it does have some evidence, particularly for those who have comorbid ADHD.
Yeah, so I am using Mirtazapine. Just logistically, I'll do a quick start, whatever setting they're on that I experience them with. And then I prescribe a month supply with 1 or 2 months refills. Mirtazapine is a relatively safe medication. You're not going to run into too many problems with it. You do need to consider if somebody's already on like other strong serotonergic substances. So MAOIs, for example, or maybe nortriptyline, amitriptyline, maybe. But it isn't as like serotonergic as other agents that we use commonly with success. What are other contraindications that you're seeing, Hannah?
We've been avoiding initiating, yeah, so there's some comments about QT. There's some evidence that it has some mild QTC prolonging effects, although less than some of the other agents that we talk about. For us, if somebody is acutely agitated or having any acute psychotic symptoms, that wouldn't be a time where we would be interested in starting it. And this is also, just to be clear, not something that we're advocating for starting in somebody who is having any kind of like decompensated medical or psychiatric conditions. This is more somebody, we think about this particularly for folks who might be coming in with sort of sporadic methamphetamine use, or who came in due to, say, maybe perhaps like a cardiac sequelae of methamphetamine use, but are relatively stable for discharge, and something that we're using more often in the outpatient setting.
Okay, thank you. Go to the next slide. We'll give you all our references. There was a recent paper that came out that was advocating for long-acting injectable naltrexone, so Vivitrol and Bupropion, Wellbutrin. And interestingly, the study model was a long-acting injection every 3 weeks. It's most commonly dispensed as an every 4-week medication with payment structures for that. And then a pretty rapid taper to high-dose Bupropion. And I know, Hannah, you've been kind of playing around with this. How have you seen that?
This is hard. This is really hard. I was relatively impressed by the studies, and I've done it a couple times, but there's a lot of contraindications to this, right? So if I have somebody who has methamphetamine use and opioid use, this is not something I'm going to do, because I need like the 1 to 2 weeks of time off of opioids before I can start the naltrexone. The study had naltrexone being administered IMQ 3 weeks, and most insurance is only going to pay for 4 weeks, and really only going to pay for the indication of opioid or alcohol use disorder. So really where this comes forward for me is like, if somebody's using both alcohol and methamphetamine, we might try to do something like this. But the other thing to throw out there is that there are also cardiac concerns with bupropion, and that there's also a lowering of the seizure threshold with bupropion. So to be honest with you, like, I was originally very excited with this study, and I went ahead and I tried to implement it. And there are just so few of my patients who are actually able to take these medications that it hasn't been something we've had a lot of uptake with, versus with mirtazapine. It seems like more of our patients might be eligible for an intervention like that.
100%, I would agree that it's been hard to find that mythical patient that's only using stimulants for me and no opioids at the same time. So we can go to our next slide. This is the treatment effect for Mirtazapine 30. So placebo, the black bar is showing that people have more of a rate of positive urine toxicology for methamphetamines, but you see the effect is there, but it's kind of small. Like, it isn't like all of a sudden people are not using methamphetamines when they're on Mirtazapine. They're just using slightly less methamphetamines, which is a significant clinical outcome and does improve patients' lives and is statistically there. But you know, this isn't the same as our wonderful like gospel that we have around Suboxone and buprenorphine. It's just a different feel, but I think it's important to provide hope and say this transaction that we're giving as a healthcare provider and a healthcare receiver, you know, we're starting this medication. I care about you. There's hope in the future. We're working together. Like, a lot of these medication interventions we're also using as like transactions to help people move in a positive relationship with us.
Yeah, I think that's a great point. And I'll say that a subset of our hospitals are actually piloting Mirtazapine out of the emergency department. We've been referencing through this Centers of Excellence program. More data to come from that as we're doing this as a QI project and continuing to iterate. But I think one of the things that we're learning is that We have to work really closely with patients to move towards adherence to this. So it's probably going to be like this plus contingency management, this plus a lot of substance use navigator support. I think with just a prescription, the rates of patients filling the medication even are going to be relatively low. And so it's finding additional ways to support patients, and mirtazapine may be one component of that, but it's probably not going to be nearly enough. Okay. We didn't want to leave cocaine behind. We have potentially even less evidence for cocaine than we do for methamphetamine, but I do want to briefly speak to some of the medications that have been studied. We're not going to go in deep depth to this, but you can see all of our references at the end and kind of check out this literature. Topiramate has been shown, particularly in a subset of people with what they refer to as particularly impulsive use of cocaine, has been found to be more effective. Who is an impulsive cocaine user? That's always been a little bit unclear to me, but certainly topiramate is something that I'll offer, particularly for people who have both cocaine use and alcohol use, which is a decent subset of my cocaine use disorder patients. We will offer topiramate to those patients. Again, we have to slowly kind of up titrate that medication over time to prevent too many side effects. And the evidence-based dose is about 300 milligrams total daily dose. There is also some evidence actually that disulfiram can be effective for cocaine use disorder. And again, potentially pairing it with patients with alcohol use disorder, although we know that adherence to disulfiram, particularly for people who use alcohol, is quite low. So I think it's a rare patient who's right for this. Other studies have had, including these studies, have had pretty mixed effects. Some of the sertraline studies have been positive, some of them have not been positive. Particularly for patients with depression plus cocaine use disorder, you might consider using sertraline. Topiramate and modafinil in combination have also been studied, as have a variety of different stimulants and ADHD treatments. These tend to have less evidence, I would say, but none of these medications are a slam dunk by any means. Anything else to say about that? Okay. This is really what we want to emphasize, though, is that we should be looking at the whole picture of the patient, right? If they have a known mental health disorder and a stimulant use disorder, let's treat both of those at the same time. If they have a known alcohol use disorder and methamphetamine use disorder, or opioid use disorder and methamphetamine use disorder, let's treat both of those at the same time. We know that if somebody uses both alcohol and meth or cocaine, potentially topiramate or IM naltrexone and bupropion might have effects for both of those medications. Specifically also for opioids and meth or cocaine, maybe you want to then do buprenorphine. Almost always you want to then do buprenorphine, and then you probably want to layer on contingency management and potentially mirtazapine as well. So those are things where we know they work. We know that that will help decrease the patient's mortality, particularly with buprenorphine. So let's use that as our first line treatment, and then kind of layer on some of these other stimulant use disorder treatments when we can. For any of these patients, we'll talk about this momentarily, there are a lot of different behavioral health options as well that can help, and contingency management is a prime one of those.
So our next pillar, in addition to medications, are things that we can do relationally with people and talk-based with people, broadly speaking, behavioral health interventions. I generally want to always partner with a specialist in this once I have decided I want to use one of those. So these are things that we are trying to modify, like the dose and the route, to make it available as much as possible into my public care hospital. And they're often found in specialty, subspecialty addiction medicine services from the counties and private care institutions. So we'll go forward. There's basically 5 proven psychosocial approaches to reduce stimulants. One is motivational interviewing. The second is contingency management, which we'll talk about in a bit. Community reinforcement approach and cognitive behavioral therapy. I feel like cognitive behavioral therapy works for everything, but maybe somebody can tell me what it doesn't work for. And we'll go forward. There's a great SAMHSA summary that, and handout if you want to read a little bit more about them, but this is kind of showing what special subpopulations might fit what kind of behavioral health intervention, and how you can go about learning more information about that. So what we really want to hone in on is contingency management in the acute care settings, to see if we can make that a low barrier thing, and to recognize that a lot of what we're doing in these transition points for our patients is providing hope and also linking to primary care. So our primary care specialists, the people that are gonna like have loving relationships with their patients over many long months and years, they are so critical for our patients to become healthy and to use less drugs. So things like, they're called medication management visits, but as much as I can tell, it's like cheerleading your patient, and therapeutic alliance, which again is just being an empathetic, compassionate person in that primary care setting, is universally going to help all of your patients with substance use disorders use less. So contingency management, what is it? It's basically providing rewards for targeted behaviors. In some ways, you can think of it as a way to gamify positive health choices that your patients are doing. And our question that we posed kind of over the past maybe 6 months to a year was, how low barrier can you possibly make some of these behavioral health interventions, so that possibly could you apply it with like a one-time ER visit, a one-time psych ER visit, a one-time hospitalization in a busy Los Angeles hospital? Like, could we just do this? And that was the question that we really kind of role played over the past year. And I want to share with you some of the lessons I learned, not to say that this is, you know, tried and true and I won, but I want to share with you something so that you can try this out in your institution and start tinkering. So what is our vision of this? This is basically, can we take somebody who uses meth and help them engage in conversations and experiences for which they'll use less meth? That's a behavioral intervention. So our vision was that we would encounter all these lovely patients who would lovingly agree to participate in our program. They would have a phone and a way to be contacted. They would want to get contact with us. They would return to some sort of scheduled care after their unscheduled acute care visit, like their ER or psych hospitalization. They would want virtual gift cards as incentives for having a certain kind of results. And then we would randomize those incentives to that specific, tangible, immediately clinically relevant measurable outcome, which in our case, we chose urine toxicology to be negative for stimulants. You can also do this and pick other outcomes, such as showing up on time for a visit, or, you know, say my own life, eating less donuts. You can imagine that this is like a mental model for which you can incentivize a number of behaviors. So that was our vision. Our real lives was, it turned out that not a lot of our patients were really interested in using less meth at the time that we talked to them about it, at that like ER visit, at that hospitalization, when asked by like their standard workforce members. So they're like usual person on their team being like, hey, do you want to be involved in this program? There's not a lot of patients being like, yeah, sign me up right now. There was also a lot of barriers that we sort of anticipated, but really didn't fully like understand, related to social isolation, losing phones, not having time or like understanding of what day of the week it was to come back at a scheduled time to do the urine toxicologies, and just a highly mobile population. So I'd see them once here in LA and be like, awesome, I kind of know where they're going to be able to come back to our hospital and do this experience. But then, you know, 3 weeks later, they'd be in another city, in another county, or another side of LA. So that was our real life experience that we found really quickly as our barriers. Go to our next slide. So then we kind of started tinkering, being like, can we overcome these barriers in these various ways? So our first effort was, hey, our general like resident on the team was just going to recruit patients to participate. That actually didn't work out so well. They were having trouble recruiting, as I say, pre-contemplated patients. Patients weren't like, sign me up. So then we're like, aha, we'll train all these workforce members to like do this a little bit better. That actually was like too much work for our residents. We're doing all these like million other things. So then our next round was like, hey, we're gonna really have to make a special squad who's gonna go out and like, when they identify a patient, they're gonna be the special trained people who are extra good at this and be able to go recruit our patients. And that sort of works, but then what we rapidly realized is just the context of like patients are showing up unscheduled to the psych ER with like a really big like danger to self, or like I'm thinking of killing myself. Like they aren't necessarily the patients who are really ready in their lives to show up, you know, next Tuesday at 7:15 or whatever to an appointment, or even to just come back and get labs. There's stuff going on in their lives that like had that unscheduled visit happen that still stayed in their lives, that made them following up for scheduled care a little bit challenging. So we really were then thinking about changing where we're recruiting to. For example, maybe we needed to change to a follow-up visit after that first psych ED visit with somebody like Hannah, like, oh, you went to Hannah's primary care appointment. Awesome. Now, are you interested in this program? Really, we wanted to, our then next level interventions would be to have a program specialist that would really manage all of this. And it'd be fine to be a non-clinician, but it became a challenge to build this program at the same time as running all the other normal clinic things that our normal clinic doctors were doing. So we're like, aha, if we were going to do this successfully, we would have to at least have a part-time specialist to really focus on this. And really considering we picked urine toxicology as being like, this is a perfect like end result that we were looking for. However, there's likely a need to broaden targets for incentives. So, hey, did you fill out your paperwork for Medi-Cal? Like that would be a great incentive, things like that. I hear in the comment section, there's a lot of awareness about the contingency management limits. We actually got a letter that said, hey, you guys are misunderstanding that limit in the sense that it was there, like if you are lower than this limit, then you automatically are cool. But if you're higher than this limit, it's not that you can't do it. It just means that you might need to have a higher level review. So when we learned that, and I'm happy to share like this information that I received, it allowed us to give a high enough financial incentives to our patients to make it worth their while. There are studies that show if you basically are giving too low of an incentive, people aren't interested, but there is like a middle ground where a number starts meaning something to somebody. All right, we'll go to our next slide. So this is a very like generic broad sample for you all to see how we tried this out. We recruited a patient by the team that was caring for that patient, or they called us for an addiction consult with somebody who had stimulant use disorder. And then we as addiction consult was like, hey, learn about this great program. If they were interested, they were immediately signed up to have access to an electronic gift card for a local area. Like I think we picked Target based on our interviews with people, like that's where they thought they could go to pretty much everywhere in LA. And they had things there that they would want in the dollar amount that we were generally incentivizing people for. And we got them a phone number. If they didn't have a phone, we tried to get them a phone. And then we also importantly gave them usual care, right? We gave them Narcan, we treated them. If they had opioid use disorder, we started Mirtazapine. We had them follow up with their primary care doctor. If they were not interested in this, which a lot of our patients were not interested, we still provided usual care, of course. So then we had a shared goal with the conversation with the patient that we really pushed the urine toxicology goal. But again, in like version next, we might pick other goals. Then we had an actual randomizer where it was like a ball of ping pongs where you'd spin it and be like, you win, blah, you know, you win $5, you win $50, you win duh. So every time they had that result, we would do the thing, show them the ball, they would get it, and they would win prizes. And that's as far as we got in our little trial of this in our very large, busy hospital. I wanted to share that experience with you so that you can start thinking through like, hey, could I do this where I live? There's a lot of information about how to run out a contingency management thing. And at first, like a year ago, I'd be like, that's impossible, cannot happen where I live. But we did try it out to just show that it's possible. And now I have some new targets to keep making it better. I think I have one more slide on this project. Oh yeah, the bewares of things that I did not anticipate that I think you guys might be smarter than me and now anticipate, which is we exist, like even though people on my team are awesome and really deconstructing their biases, we live in a culture that is still very stigmatized against stimulants. So having a number of urine toxicologies in a medical record had unintended possible consequences, such as you could imagine female of reproductive age with now a pregnancy with documented urine toxicologies showing positive things, even if it was unrelated to stimulants, like lots of weed, random cocaine, random, you know, like all that thing that had unintended consequences that we did not originally think about. So the other thing we didn't think about that had unintended consequences is if somebody doesn't understand Suboxone and buprenorphine, and you know, my patient would be stable and negative for opioids in their urine toxicology on buprenorphine, a complete treatment success, but they would then see a primary care doctor who might not know much about the situation, be like, oh, you have weed in your urine or whatever's. Therefore, I should cut all the controlled substances, you know, like punitively old school model. I'm going to deny care for you to continue your buprenorphine, continue, you know, whatever other kind of controlled substances they might need. There was like uneducated providers seeing a medical record that we well-intentioned created a bunch of urine toxicologies for. And also, you know, just the usual stigma and bias around the issues. We ask people to come frequently into care, like come to the lab, drop your urine toxicology off. Well, if your security guard on Saturday just isn't like totally on board with people experiencing homelessness who look like they are actively intoxicated on alcohol coming in to drop off at urine toxicology, like that patient is going to be exposed to a lot of interpersonal microaggressions from our medical staff. And that was something I did not totally think through. And the biggest thing, this did not happen, but after like seeing all these other things pulled out, I was worried that like something like DCFS would be called inappropriately because of positive urine toxicology that I was collecting. So those are the possible like negative unintended consequences that I learned from rolling this out that I think you guys can foresee and do something about before rolling it out. Go ahead.
Yeah, gosh, that was super helpful. And I think we're all, contingency management has been pretty extensively studied in the outpatient setting in pretty comprehensive programs, right? As a part of a system that involves groups and medication visits and things like that. So trying to figure out how to do a relatively bare bones contingency management is sort of a new space of exploration. I'll say some examples in addition to what Rebecca has provided is that, for example, at my hospital at San Francisco General, we had a pilot program for people who were admitted to the hospital with heart failure exacerbations due to stimulant use disorder. A subset of patients who were interested in it were able to do a time-limited contingency management program that was embedded in the cardiology clinic. So something like that, where you pair it with a service that the patient is already interested in getting and work with them to decrease their use of stimulants, can be really effective. And I'll just echo that, particularly for women of reproductive age, we a couple of years ago had tried a program for pregnant and postpartum women that involved contingency management, and the urine toxicology thing seems really just to be too fraught in that population. So it's possible that you might be able to make that work somewhere, but helping people feel secure enough that their urine toxicology results will not be used against them when Child Protective Services is involved in any way has been a real challenge, and we can very much understand why, because there's a long legacy of those results being misused. In the interest of time, I'm going. Rebecca, I think you had one more there. Anything?
Yeah, thank you. So one thing that we did learn is that not a lot of people knew about contingency management. Like even our own team, we had to learn a little bit about it. So in order for this to work, the very, very first step is you get to go kind of on a road show in your medical system and have potlucks with everybody being like, hey, do you guys know about contingency management? Just so that word is out there and people understand what you're doing. That is what I'll have to say about this slide.
Great. I want to talk about harm reduction because as much as we've talked about the struggles that our patients face when they're trying to cut back or quit using, we also need to acknowledge that some of these treatments are not super effective. Not every patient is willing to stop using. So let's talk about living well and harm reduction. One, we're talking about fentanyl contamination of stimulants. This is spotty across the state, but fentanyl contamination has definitely been seen in both cocaine and methamphetamine. Fentanyl test strips are often false positive for meth. So essentially meth cross-reacts with the immunoassay on a fentanyl test strip. And in many, many, many cases, a patient whose meth tests positive for fentanyl will not actually have fentanyl in it. It'll just be a high concentration of meth. Historically, there was a lot of recommendations around highly diluting your methamphetamine sample prior to using a fentanyl test strip. Now, some harm reduction organizations are actually just saying fentanyl test strips probably aren't going to make a big difference for meth. Maybe we shouldn't be recommending them for meth. And instead, we should just be recommending universal precautions, such as always using with a buddy, having Narcan nearby, and using test doses prior to using your meth. For cocaine, that cross-reactivity is less of a problem, so fentanyl test strips can be a really good option and should be something that we're distributing in all of our sites, kind of no matter what, right? Including for our patients who use heroin, who buy benzo bars on the street, all kinds of folks may benefit from fentanyl test strips. Multiple of our California Bridge hospitals are also now doing harm reduction kits that go beyond just Narcan and fentanyl test strips, or naloxone. I apologize for that brand name there. So this is an example of what a methamphetamine bubble smoking kit can look like. So there's a pipe in there, there's a mouthpiece, so that if you burn your lips and you share a pipe with somebody else, you don't have contamination by your blood. There's an alcohol swab, and then there can be a lighter in there. These are just some of the things that go into some harm reduction kits. We really recommend all of our hospitals and all of our outpatient programs partner with your local harm reduction organizations, see what makes sense to distribute to your patients for stimulants. No matter what kind of stimulant somebody is using, harm reduction to prevent people from getting overly intoxicated or having really significant medical sequelae of their use includes using relatively small doses at first to understand the potency of what you're using with other folks who are trusted in a calm and loving space. Drinking a lot of water. So this is one of the things that we are always trying to counsel our patients on, is making sure to stay hydrated while using particularly methamphetamines, making sure to eat when you can, and then making sure to stay well rested. It's often when folks aren't able to get food, water, and sleep that we see presentations with really significant methamphetamine intoxication and even things like rhabdomyolysis. There are a variety of different things that folks can do to use in a safer way. So that includes also moving from injection to things like snorting or smoking, or depending on the lingo that you're using, either booty bumping or boofing. So like using intranasal smoked or intraanal use of your drugs. One thing that I do want to point out is that it can be really common that people will use stimulants together with during their sexual experiences. That's something that we should be counseling all of our patients on, harm reduction around that, and particularly then the use of condoms and lubricant when you are doing that. There's an increased risk of HIV and other STI transmissions when chemsex is occurring. So making sure that people know about PrEP, making sure people have condoms and lubricants, and then particularly if you are doing intraanal or intrarectal use of your drugs, making sure there's an increased risk of sort of like skin and soft tissue breakdown and an increased risk of blood transmission. So those are times when we really want to be making sure that we're counseling our patients appropriately about harm reduction.
And we've also talked about doing quick start contraception for people at risk of pregnancy, in addition to really being open about starting PrEP. So a lot of people have different kinds of sexual encounters, whether it's transactional sex to obtain drugs, or they're using drugs and then having more sex. And that might be a great time, for example, to use PrEP on demand. So for that weekend, they're using PrEP or something like that. And we can talk about that at some other time. But there's a lot of great things that we can do to keep our community safe.
That's a great point. Thank you so much. We need to be wrapping in sort of like contraception and birth control and kind of whatever people need for their sexual health into kind of all these interactions.
This is my phrase all the time in my ER. We're seeing Narcan responsive methamphetamine overdose. So a lot of meth is contaminated with fentanyl these days. In LA, there was, I think, a study 4 or 5 years ago that was showing about 7% contamination with fentanyl. I'm sure it is now a lot higher. So this is just reminding all of us when we have patients who use stimulants to ensure that they also have a lot of Narcan. Even though they're not using opioids, they might unintentionally be using opioids.
Great. Okay, so we have about 5 minutes left. We're going to give a couple wrap-up slides and then probably pause for some questions at the end. So I know that we've given you a lot of maybes, and I know we've given you a lot of there's not a ton of evidence, but I did want to put together a sort of comprehensive way of thinking about this whenever a patient presents with stimulant use disorder. So if somebody comes into the ED and they're acutely agitated, like let's make sure first and foremost that their symptoms are managed, that they're safe, that they're in a space that feels calm and quieting. If a person is open to it and they don't have a contraindication, considering a mirtazapine quick start with that 30 milligram starting dose, considering harm reduction options for those patients, including naloxone, a bubble kit, potentially fentanyl test strips, mostly for those cocaine use disorder as opposed to the methamphetamine use disorder. And then considering like, what is the role of your substance use navigator here? Substance use navigators on the call, I know I've been seeing you put amazing things in the chat. Substance use navigators can really have like a strong role in linkage, and we can use contingency management to support linkage. And substance use navigators can, no matter what treatment a patient receives, do a 7-day follow-up call, provide those wraparound services, and make sure that patients are sort of feeling the love and feeling welcomed into whatever treatment program we're recommending for them, if that's their preference. Outpatient, it's a lot of the same. It's contingency management is probably a little bit more first line in the outpatient setting. Treatment of comorbid substance use disorders, treatment of comorbid mental health disorders, and physical disorders as well, right? And then also offering more of a menu, I think, of medication. So I put mirtazapine here, but we discussed a lot of different options. Many of these are a better option for us in the outpatient setting than in the acute care setting. And then always wrapping harm reduction and living well into any interaction that we're having around stimulant use. I think maybe we'll skip our case, yeah, in the interest of time, and maybe just transition into Q&A. I also want to throw up here before we dive deep into the Q&A, check out our resources on the webpage. There is not a lot there about stimulants, but what we've been talking about today is going to get distilled down into a document. And we do have a lot of resources on harm reduction, alcohol, opioids, kind of you name it. And then if you need any help from us, any technical assistance, please go to the link. You can scan the QR code here and we will be able to connect with you. I'm going to turn it over to Elizabeth to wrap us up.
My only little plug is to reach out to us for technical assistance, no matter what state you're from. You don't have to be from California. We can help you. And that I have put the link to the to claim CME for this session in the chat multiple times. So do go claim that CME, and we'll take a few questions. Here's a question that I think Hannah and Rebecca could both talk for another hour about. What do you say to behavioral health providers who insist that substance use disorder be treated first before mental health issues? So frustrating.
I'll take a stab at this. So, you know, we've all been guilty of this. It's hard to make a DSM diagnostic criteria in the setting of substance use disorder and mental health and physical issues, right? But the reality is that our patients are in front of us in a moment and they're asking for some sort of support, and we should be providing whatever support we can provide, right? And so if I can manage the symptoms that you are feeling right now, that is something that I need to be doing. If I can manage the substance use disorder you have, by all means, let me do that. But also let me provide support for your mental health. And we can really get a history. We can tease apart what was your mental health like when you were an adolescent? What was your mental health like before you started using these stimulants? And then what are the symptoms in your mental health that are driving you to use these stimulants? With that information, I think we can make basic diagnostic decisions and start to manage patient symptoms and help them to feel better, both from a substance use disorder front and from a mental health front. Rebecca, I wonder your thoughts on that.
Yeah, I completely agree. I generally am, you know, family medicine trained, so I'm like, treat all the things all the time, you know, at any possible moment of intervention. So that's a great question. I think we luckily don't have to separate things very much anymore to provide, like, for example, Mirtazapine is going to help somebody with depression and their stimulant use disorder. So I think we have a lot of these flexitarian kind of approaches to treatment that are really showing up well for our patients. I know Hannah and I can literally talk for hours about all of these issues, so we're always available if you think of a question later today. Email us, call us. We love talking about this issue, and we're here to help. We'll stay on a couple more minutes. You guys, those who have to go to busy clinics that start next, happy to have you log off, and we'll continue staying on and finish these questions. Emily asks, can you talk about how to recognize a stimulant overdose? Hannah, how does that show up for you in your clinic setting?
In my clinic setting, it doesn't show up all that often, but in my acute care setting, it does show up. Certainly we see folks with tachycardia, hyperthermia, agitation, things like that. It's a pretty common presentation to the acute care setting, right? And it's just in part symptomatic treatment, but then in part also asking the patient about what they've been using and having an open and honest conversation about that.
Yeah, that's looking like rhabdomyolysis, kidney failure, heart problems like MIs, heart failure. So generally we're treating all those medical issues first. It's not as beautiful as, you know, opioid overdose Narcan. It's kind of treating the sequela of those issues and helping people kind of calm down their brains and bodies.
Yeah. I'm seeing some folks saying, like, I'm concerned about the quality of evidence for these medications. I too am concerned about the quality of the evidence for these medications. So this session is really meant to be us sharing the existing literature that is out there. And I think this is something where we're all going to be exploring together what's going to work for our individual patients. If you're thinking about implementing a program like this, like, let's talk more about it. Email us, be in contact with us. We can share the protocols that we're using at our institutions. And I think this stuff is going to evolve a lot over time.
There was a question about handle meth-induced mania or kind of psychosis, maybe when a person's on buprenorphine or mirtazapine, maybe we just started them and that worsened it. I would go down on or stop the bupropion. I don't know if I just misspoke earlier, but the Wellbutrin. The mirtazapine generally does not induce mania as much as other SSRIs if you have like undiagnosed bipolar or something like that. So I generally wouldn't blame the Mirtaz. I would tend to blame a little bit on the Wellbutrin, and then handle it symptomatically, you know, again, just kind of like the early agitation slide that we saw earlier in this deck about how to keep somebody calm, cool, collected, and medically, chemically bring them down.
Yes, and then addition of mood stabilizers or antipsychotics as necessary. And of course, I think most of the folks on this call are not psychiatrists. I know there are some psychiatrists on the call. That is definitely a time where we bring in our psychiatry colleagues and work together on this.
Yeah, exactly. If you're having an ongoing mania, if you're like, oh, wow, this patient actually has, this other diagnosed issue that we're now uncovering. Yeah, I agree. The mood stabilizers tend to help. All right. Thank you, everybody. What a wonderful day. Have a great rest of your summer.
Thank you so much.
Thanks, Rebecca and Hannah.